Imagine this: a patient walks into the emergency room with a low urine output, raising creatinine and swelling. Within an hour, their kidneys could completely shut down. This is acute kidney injury, a sudden, often reversible decline in the kidney function that can decide life or death. Today, let's break down AKI, that is acute kidney injury, like never before. The causes, types, clinical features, and management, along with these powerful clinical pearls that every healthcare professional should know. If you love high yield clinical relevant breakdowns, hit subscribe now and turn on the bell so you won't miss the next one. So, what is AKI? Acute kidney injury, sometimes called acute renal failure, is when your kidney function suddenly declines over days to weeks. Patients often have reduced urine output. Well, AKI is common. It affects about 7% of all hospitalized patients, and in acutely ill or ICU patient, that number jumps to 20%. Now, the outcome depends on the context. In the straightforward cases like in blood loss or drug induced AKI, recovery is often good even if the dialysis is needed. But in the patient with an severe sepsis and multi organ failure, mortality skyrockets to 50 to 70%. And in this situation, death is usually due to the underlying illness, not the kidney failure itself. That's why early recognition of the AKI is absolutely critical. So let's see the classification of AKI. To make sense of AKI, think in three buckets. One is pre-renal, when the blood flow to the kidney is reduced. The second one is a renal, where the kidney tissues itself is damaged. And the third one is post-renal, where something blocks urine flow from the kidney to the urethra. This framework is gold. It helps us reason through the causes, diagnosis, and the treatment. Let's start with that pre-renal AKI. This happens when the kidney does not get enough blood flow, what we call the hypoperfusion. What are the causes? Think of hypovolemia, which is low blood flow to the kidneys, which may be due to the hemorrhage, fluid loss in burns, trauma, or sepsis. Even relative hypovolemia, like an septic shock with an vasodilation, can trigger the pre-renal AKI. The patient typically look hypotensive, tachycardic, which means an increased heart rate, with an cold extremities and delayed capillary refill. And also, it may be due to postural hypotension, where BP drops greater than 20 over 10 mmHg when standing is an early red flag. Biochemically, you will see metabolic acidosis and hyperkalemia. Here is the twist: pre-renal AKI does not always need low blood pressure. The NSAIDs and the ACE inhibitors can cause us it too, because they interfere with the renal blood flow regulation. And if then hypoperfusion persists, it progresses to the acute tubular necrosis, where the tubular cells die, slough off, and block the urine flow. Under the microscope, you would see breaks in the basement membrane, interstitial edema, and necrotic cells clogging tubules. By the way, if you are finding this clinical breakdown helpful, go ahead and hit that like button. It tells me to keep making more high yield breakdowns just like this. If you didn't subscribe to our channel so far, please do so now. Now let's discuss about the renal causes of the AKI. Now, if the kidney itself take the hit, we call it renal AKI. Two big culprits dominate here. One is nephrotoxic drugs such as gentamicin, cisplatin, amphotericin B, and even proton pump inhibitors like omeprazole. These can cause either ATN, acute tubular necrosis, or acute interstitial nephritis. And the second culprit here is glomerulonephritis, where the inflammation damages the glomeruli. These patients show hematuria, proteinuria, and sometimes systemic features like SLE, that means systemic lupus erythematosus, or vasculitis. You usually need a renal biopsy to confirm the glomerulonephritis, while the interstitial nephritis is suspected when the kidney function crashes soon after starting a new drug. Always keep the drug history in mind. Finally, post-renal causes of AKI. Here the problem is obstruction. Anywhere from the tubules down to the urethra, the causes include stones, tumors, fibrosis, or even bladder outflow obstruction from the prostate enlargement. So, the patient may have a palpable bladder. Ultrasound often reveals the hydronephrosis, but be aware in the cases of fibrosis or malignancy, and hydronephrosis can be absent. And sometimes post renal obstruction coexists with an intrinsic renal disease like acute tubular necrosis, which makes the diagnosis trickier. So, how do we pick up AKI early? Step 1 is screen every emergency admission. On arrival, check renal functions, BP, pulse, temperature, and risk factors. And the risk rises with an diabetes, vascular diseases, liver diseases, or nephrotoxic medications like NSAIDs and ACE inhibitors. If you find a high serum creatinine, always ask, is it acute, or is it acute on chronic or long lasting CKD? Previous records of renal function are gold for sorting this out. So everyone with an AKI get blood tests, urine analysis, and ultrasound, and the extra tests like immunological panel or biopsy depends upon the suspected causes. To classify severity, we now use KDIGO criteria based upon the creatinine rise and then urine output. These aren't just academic, they guide treatment and predict the prognosis. Okay, so once we suspect AKI, what next? Management has universal steps regardless of the cause. Identify and treat the underlying trigger, whether it's an hypovolemia, sepsis, obstruction, or drug toxicity. Stop the nephrotoxic medication, if any. Correct the fluid and electrolyte imbalance, especially hyperkalemia and metabolic acidosis. Monitor urine output closely, and when needed, initiate the renal replacement therapies like dialysis. So, anemia is common in AKI, sometimes from the blood loss, hemolysis, or reduced erythropoietin. Plus, established AKI reasons the risk of bleeding, especially gastrointestinal, due to uremia. Always anticipate and monitor for these complications. So, just to recap, AKI is common, serious, but often reversible. Classify into pre-renal, renal, and post-renal causes. Spot it early with a simple bedside checks. Use KITCO criteria for severity. Management focus on reversing the cause, protecting the kidneys, and supporting the patient. Remember, saving the kidney often means saving the patient's life. Now, we are breaking down the management of acute kidney injury. We'll cover the fluids, electrolytes, acidosis, dialysis, recovery, everything you need to know step by step within clinical pearls and the drug connections along the way. Let's dive in. First thing first, what kills quickly in the AKI? It's not creatinine, it's unstable hemodynamics. If the hypovolemia is present, correct it with an intravenous fluids or the blood. But here is the pearl, don't overdo it. Excess fluid can backfire, causing the pulmonary edema, a disaster in the AKI patients. Monitor central venous pressure can help guide fluid resuscitation in clinical setting. Which fluids? Balanced salt solutions like Hartmann's or Ringer's lactate are often preferred over plain saline where the large volumes are needed. Why? To reduce the risk of hyperchloremic acidosis. Does this change outcomes dramatically? The evidence is mixed, but clinically it makes sense. What to avoid? Hydroxyethyl starch solutions. They have been linked with an higher rates of established AKI, and in unstable critically ill patients, sometimes fluids alone aren't enough. They may need inotropes to restore the blood pressure. but do not reach for low doses dopamine. The trial shown no benefit in the AKI protection. That's a myth buster. Next challenge is hyperpotassium and acid base. Hyperkalemia is a silent killer in the AKI. It's common in the patient with sepsis, burns, hemolysis, or metabolic acidosis. If the serum potassium is above 6.5 millimole per liter, treat immediately to prevent the life threatening arrhythmias. And remember, AKI almost always brings an metabolic acidosis unless the patient is losing the acid through the vomiting or gastric suction. Severe acidosis, you can use sodium bicarbonate provided the patient's volume status allows. Correcting the volume often helps kidneys function recover, which naturally fixes this acidosis. So, the pro tip here is sodium bicarbonate infusions like 50 ml of 8.4% are also handy for reducing the hyperkalemia in emergencies. Now, let's zoom into the lungs. Pulmonary edema is a classic complication where the fluid exceeds what the kidneys can excrete. If the patients cannot produce a urine fast enough and the diuretics fail, the next step is dialysis to remove the excess fluid. In the meantime, respiratory support might be needed. CPAP, that is continuous positive airway pressure, which delivers a constant stream of pressurized air through a mask, keeping the alveoli open throughout the breathing cycle. Or intermittent positive pressure ventilation should be given. Once the resuscitation, here is the golden rule. Match fluid intake to the urine output plus 500 ml to cover the insensible losses. If the patient also have diarrhea, add extra fluids. Think balance, not overload. AKI patients often get dilutional hyponatremia, usually when they drink too much despite being oliguric, or if they have given too much IV dextrose. What's the prevention? Careful attention to the fluid balance and slow the controlled infusions or of IV fluids. Other electrolytes. Hypocalcemia is common but usually mild and rarely needs a treatment. Hyperphosphatemia is the rule, but here is the twist. In patients on daily or continuous dialysis, phosphate can drop dangerously low, so replacement may be needed. Let's not forget the nutrition can make and break recovery. The patients with an AKI, especially if septic or burnt or hypercatabolic, they need enough calories and a moderate protein intake, but not excessive. Because high protein versus the uremia, enteral or even the parenteral nutrition may be required. Remember, starving the patient slows the recovery. Another pearl is infection risk skyrockets in the AKI. Both humoral and cell immunity are impaired. Daily clinical checks up targeted microbiology are essential. If the infection is present, treat promptly with an right antibiotics and dose adjust for the renal function. So now drugs. Always check for the drug-induced causes of AKI like aminoglycosides, amphotericin, or contrast. If you suspect drug-induced tubular necrosis or interstitial necrosis, stop the offending drug immediately. Also, discontinue non-steroidal anti-inflammatory drugs and the ACE inhibitors. They can prolong the acute kidney injury. Give H2 receptor antagonists to prevent the stress ulcers and GI bleeding. And remember, dose adjusts are essential medicines. Stop non-essential. This is where the pharmacy saves lives. Not all the AKI is tubular. In glomerulonephritis, management may require immunosuppressant, plasma infusion, or plasma exchange. And if it's post-renal AKI, don't forget the basic. Relieve the obstruction. Using urethral catheter for bladder obstruction, ureteric stent for or precautionary nephrostomy for ureteric obstruction. Despite our best efforts, some patient won't recover quickly, and that's when renal replacement therapy (RRT) comes in. What are the indications for the RRT? Hyperkalemia, fluid overload, severe acidosis, or rarely uremia with pericarditis or encephalopathy. No magic cutoff for the urea or the creatinine exists. It's all about the clinical picture. But remember, renal replacement therapy like dialysis carries an risk line infections, hemodynamic instability. So it must be an individualized decision balancing the risk and the potential recovery. The options include hemodialysis, high volume hemofiltration, hemodiafiltration, and some settings peritoneal dialysis. So now finally the recovery phase. It usually starts with a gradual increase in the urine output followed by the famous diuretic phase where urine output skyrockets for days before settling. Why? Because the tubular damage and the loss of the medullary concentration gradient temporarily prevent urine concentration. During this phase, the patient may lose large amount of sodium, potassium, bicarbonate and phosphate. Supplements may be necessary until normal tubular reabsorption is restored. Then, step by step, the kidney recovers if the underlying cause has been treated in time. So, to wrap up, stabilize the hemodynamics without drowning the patient, control the potassium and acidosis aggressively, prevent pulmonary edema with careful fluid balance, correct the electrolytes and the nutrition issues, treat infections fast, review all the medication and stop the harmful ones, consider immunosuppression or obstruction relief if relevant, start RRT only when clearly indicated, and guide patients safely through the recovery phase. That's the holistic, high yield approach to manage the AKI. So, if this breakdown helped you connect the dots, don't forget to like this video, share it with your colleagues, and subscribe for more clinical deep dives. Drop a comment with your toughest renal question. We will tackle it in the further episode. This is Pharmacy Made Easy, turning complexity into clarity. Until next time, keep learning, keep saving the lives. Thanks for watching. Follow Pharmacy Made Easy.